Can everyone see that? And feel free to enter questions in the chat box as we go along. Holly's going to help us monitor, and we're more than happy to be interrupted during the course of our presentation. We will leave a fair amount of time at the end for questions and answers, so you can also save them for the end. This topic, I think, is a mutual passion of both Diana's and mine, to be able to talk about long-term care and advocate for better long-term care. And for me in particular, one of the whole reasons I became a geriatrician is the recognition that for most people, with the rare exception for individuals who are lucky enough to live a robust and healthy life and then just die peacefully in their sleep, most individuals will experience a matter of time, years, maybe even decades, with some amount of debility, some kind of functional impairment, either related to physical or cognitive impairments. And so when you think about the huge population in our country who need assistance with their day-to-day care and are completely uncoordinated, unsupported system of social care in this country. Hopefully by the end of this presentation, you'll come to understand why Diana and I care so deeply about long-term care, and our push to try to make it better for the people who require it. So these are our objectives for today, is to learn about options for long-term care facilities in terms of regulations and eligibility. And we are focusing our talk on facility care. There is, of course, long-term care in the community, in the home, but for today's purposes, we'll be looking primarily at facility care. Diana will discuss the role of the long-term care Ombuds program and how they can help people address concerns that they have about the care that's received in facilities. And then I'll talk a little bit about the impact on patients and families that's happened due to the COVID pandemic, with the social distancing restrictions, and encourage people to gain skills to advocate for family members and friends and improve the long-term care experience. So we'll start with the first objective. So, first to define, what is long-term care? It is care that's provided when an individual is no longer able to manage their own daily needs. So it's really wide-ranging. It can be someone who simply needs help with shaving or toileting, but it can extend all the way to someone who is unable to roll over in bed themselves, who needs help to sit up, who needs help with bed baths and transfers. Sometimes this type of care is called custodial care, non-medical care, or personal care, and it's distinguished from skilled nursing care, and this is a key distinction when you think about the facility options that are available and the payment for them. So most individuals are having some type of difficulty with their activities of daily living, and it can stem from physical or cognitive problems. So we just define activities of daily living as the core basic things that a person needs to survive, to be able to bathe, to eat, to have continence, to walk and transfer, to get dressed, as well as what we call instrumental activities of daily living, how to manage a person's finances, how to cook, keep their living residences clean, how to obtain transportation, and to use a telephone. There's a wide range of services available in the community to help support individuals to remain in their own home. So this can range from in-home caregiving, so either hiring private duty caregivers, utilizing informal caregivers such as family or friends or neighbors, and it can include daycare, such as what the Grace Adult Day Care Center offers in Corvallis for individuals who have dementia. This is a great option for people who still want to live at home, but their caregiver perhaps still works, or the individual needs a more stimulating social and structured environment during daytime hours. It can include transportation services to help someone access their medical care or to go to church. It can include skilled home health, meaning a visiting nurse, a visiting physical therapist, occupational therapist, etc. Facilities come into the picture when remaining at home is no longer a safe or sustainable option for a variety of reasons. Either safety reasons because the care needs of the person exceed the abilities or the time available of the caregivers, or it's no longer sustainable, perhaps because of financial and economic reasons. This is a table that describes the core types of residential long-term care settings and what they're called in Oregon. In some states, they have different names. So you can see the 4 columns here: assisted living facilities, residential care facilities, adult foster homes, and skilled nursing facilities. And to give you a sense of sort of how they differ, assisted living facilities and residential care facilities, you can think of more as sort of generally larger complexes, perhaps large apartment complexes, generally with private or sometimes shared living units. They may have private kitchenettes and private bathrooms in assisted living facilities. Whereas an adult foster home is generally a home that has been repurposed for as many as 5 residents with shared or individual rooms with community kitchen and community living spaces. A skilled nursing facility is the classic nursing home that most people think of. It provides both short-term rehabilitative care and nursing care when someone is coming out of the hospital, but many nursing facilities also provide long-term care for those who have chronic illness or disability. The oversight for these types of facilities are vastly different. So for skilled nursing facility care, they are overseen and regulated in large part by the Centers for Medicare and Medicaid Services. They are, in fact, quite tightly regulated. For assisted living facilities through adult foster homes, it's very different. These are state by state oversight, and in Oregon, it's overseen by the Oregon Department of Human Services with the Office of Licensing and Regulatory Oversight. If you look at the staffing requirements, it's also hugely different. So with the exception of skilled nursing facilities, there is no staffing requirement and no ratio, that is no minimum ratio required in any other residential facility except for skilled nursing facilities. There was a recent legislative bill that went through our state legislator that was put together by Sarah Gelser, our local congresswoman, that is meant to improve staffing ratios in memory care, but only in memory care facilities. The staffing requirements are very vaguely written, as a facility must have sufficient qualified awake staff to meet a resident's 24-hour scheduled and unscheduled needs. Caregivers' duties and qualifications can vary, and caregivers do not have to be certified nursing assistants. This is very different from a skilled nursing facility or a nursing home, where statute has specified a clear number of residents to CNAs and a minimum number of nursing hours. To give you a sense also of what the leadership of these facilities is, in a skilled nursing facility, nursing home directors are required to have a college degree and complete a 6-month course. For assisted living facility directors, they have to have a high school diploma and complete a 40-hour course. So you can see the vast difference in the type of leadership that is overseeing these residences. Nursing care in assisted living facilities, residential care and adult foster homes. In assisted living and residential care, they have to have a registered nurse on staff or by contract, but the nurse does not have to be on site 24 hours a day. They rarely are. And in adult foster homes, they do not require a registered nurse, but they have to be able to access a contract nurse as needed. And this might be for providing consultation to the foster home about care needs, an assessment, or delegating skilled nursing tasks and reviewing medications. In a skilled nursing facility, there has to be a full-time director of nursing and a full-time charge nurse available on every shift of a 24-hour cycle. To also give you a further sense of the differences in level of care, a med tech in a memory care can often do more than a bachelor's of nursing science can do in a nursing home, just simply because of the differences in regulations and oversight. Who pays for long-term care? So oftentimes it's out of a person's own pocket or family's pocket. It's generally private pay. The average monthly cost for assisted living facility in Oregon, with data from last year, is about $4,600 per month. There is an additional monthly cost of about $1,000 or more for memory care. And I forgot to mention that, assisted livings, residential care facilities, any of these non-skilled facilities can get additional certification as a memory care facility if they apply for it and have the appropriate processes in place. For adult foster homes, the average cost, and I was only able to find 2015 data, is about $2,100. It's obviously more now. And the average monthly cost for a private room in a nursing home is about $10,000 in Oregon. If you have long-term care insurance, you were lucky enough to start paying into it when you were healthy and younger, generally this can help provide partial payment for long-term care residences, but it really depends on your benefit as to how much is covered and what duration you can have those funds extend to. Medicaid can help cover long-term care. So if someone is low enough income and or on disability and qualifies for Medicaid, Medicaid can cover long-term care. We are very lucky in Oregon because in some states, such as California, where I come from, Medicaid will only cover nursing home level care. But in Oregon, our Medicaid does enable someone to get Medicaid supported care in an assisted living facility, in memory care, or in an adult foster home if those facilities are contracted to receive Medicaid residents. Veterans Aid can also generally provide support for long-term care. And the one crucial piece that is important for people to know, because it is a common misunderstanding, is that a person's Medicare coverage does not cover any kind of long-term care. The only time Medicare covers some amount of long-term care is when someone goes to a skilled nursing facility, generally for temporary rehabilitative or skilled nursing services, with the intent that that person will get stronger, recover, get better, and be able to transition back home or transition on to whatever long-term care placement they need. But of course, we know that in some situations, someone may start off in skilled care in a nursing facility, not be able to recover, and wind up needing long-term care in that nursing facility. So I'm going to now turn it over to Diana, because the reality is that we know that in many facilities, care doesn't always happen the way that a resident or a family would like and or has agreed upon in their care plan. And so what do families and residents do when they feel like they're not getting their care needs met? And how do they go about getting concerns resolved?
Okay. I'm going to start with a point of trivia. The word ombudsman was borrowed from the Swedish, where it means representative. And in the early 1800s, Sweden became the first country to appoint an independent official known as an ombudsman to investigate complaints against government officials and agencies. So that was something that I learned in my ombudsman training. So the program in Oregon was established in 1981, and it is part of the Older Americans Act and provides advocacy for people living in long-term care facilities. And there is both federal and state authority that drives a program. In Oregon, we're an independent state agency, and we answer only to the governor. There are over 45,000 residents statewide living in some type of facility, And I think now we have over 685 facilities, and that would include nursing homes, assisted living, residential care, and adult foster home. Right now, there are 16 paid staff and 145 to 160 volunteers. An interesting point here is in 2020, there were 9,535 volunteer hours given, and that was during COVID. So those hours are mostly by phone, because we were not allowed to go into facilities and do visits due to COVID. So in contrast to that, in 2019, volunteers made 11,997 visits. So that would be physical visits to facilities. So those have not happened. In the last few months, we've been able to, I think since March, have been allowed to go back into facilities. But most of our time before that was just hours on the phone with facilities and with residents living in care. Next slide, please. So my start as a certified long-term care ombuds, this is a picture of my mama, Janet. And we moved her to Oregon in 2012. She first lived in independent living and then in assisted living for a couple of years. And we knew she was having some memory issues even before we moved up here, moved her to Oregon from San Diego, issues with judgment, decision-making, but she was still doing pretty well. We didn't realize how much of a problem it was until she started wandering, something I thought she would never do. So she had a red walker, and she was 2 miles away from her facility once, and they didn't even know she was gone until they got a call from the police, which is a problem. And she was looking for her house in San Diego. After that, she lived in memory care for 2 years, from about 2015 to 2017 when she died. And while she was in memory care, I would visit her twice daily, usually on my way to work and my way home. And part of that was to help take care of her kitty, Smokey, who was allowed to be with her. And I would feed him and scoop poop twice a day. And I spent quite a bit of time there. So I got to see the interactions between residents, with each other, and residents with staff. And I saw things that I liked and saw things that really concerned me. And one thing that I really absolutely believe is my mom received a higher level of care and quality of care because I was there so much. And I got to know the residents, and I got to know the staff. So I know that she was looked after better than other residents. And while I appreciate that a lot, it's not right, you know. I was lucky because I lived where I could see my mom daily. There are many residents who aren't that lucky, that they don't have family close by, or don't have family, or don't have a relationship with family, so they're not seen. And it's just as important that those residents receive the quality and kind of care that my mother mostly received. But I think that really happened because I was able to be there. And before I retired, I knew I wanted to be a long-term care ombudsman. And as Helen mentioned, you know, a passion for me really is people with Alzheimer's and other forms of dementia, people that don't have a voice. My mom, the year before she died, fell and broke her hip, and it ended up being a case that was investigated by Protective Services because her care plan was not being followed through. She was a fall risk, and they were not on the ball taking care of things. And she fell, and they didn't even know she fell. Another resident with memory issues had to notify them that my mother was trapped and crying for help. So I really wanted to be an ombudsman. Next slide, Helen. While my mom was in care, there's things that I wish I'd known, that my mom had rights. There are a lot of rights, and they are posted in facilities that may not be the most visible place for people to see. And there's also a poster about the long-term care ombudsman program and where people can go if they have questions or concerns. I also wish I better appreciated that my voice matters, that I was an advocate for my mom, once, especially since she went into memory care. And that if I didn't speak up for her, who was going to? It wasn't the staff and it wasn't anyone else. I needed to be there to do that. And also that it's okay to ask for help, either from Ombudsman office, people you trust, someone that can help support you in your questions and concerns during this time. Next slide, Helen. So to become a certified ombudsman, things that we learned during our training is that residents have rights, choice matters, what they want matters, that it's important to honor and respect that their day-to-day quality of life, and to provide care with dignity and respect and interact with people, providing dignity and respect. As an ombudsman, we don't make decisions for residents or act as their legal representative, and we don't provide care for them. Our role is to inform the resident of their rights and then act upon their decision.
This is Helen, yeah.
Sorry, just a second. We are, our service is voluntary, and we provide a free and confidential service. We investigate on behalf of residents, and in speaking with residents or speaking with their family, we know that often people are afraid to make a fuss, or they're afraid of retribution. They lack trust. They're afraid of what might happen. And so it's important as a certified ombuds to, with time, build trust with the family, with the resident, and hopefully better be able to support them in their decisions around their care. As an ombuds, we monitor care that residents receive with their permission. We monitor staffing, building conditions, and we'll work with facilities to correct problems that are happening. And first and foremost is knowing that residents have the right to live and to make choices just as if they were on their own in their own home. And it's important that we always remember to focus on their day-to-day quality of life. Next slide, Helen. So every year in the State Ombudsman Office, they'll compile the top 10 complaints that happen in facilities. And as you can see, in 2020, there were a lot, over 2,700 complaints. And those are broken down by facility type and by type of complaint. And I'm going to talk about a couple examples. And some of them, as you can see, are around things like food service, care planning, housekeeping, and then there are more serious ones. There's one that is a real life example that was part of our training, is around resident rights. So here's a scenario for you. A resident sees that chocolate cake is being offered for dessert, and he's excited to have that. And when it's his turn, a plate of sugar-free Jell-O is placed in front of him. And he asked for the cake instead. And he's told that, you know, we're trying to watch your diabetes. You know what your doctor said. You need to watch the amount of sugar you eat. So this sugar-free Jell-O is better for you. That's what we're giving for you. And the resident says, well, I want cake. And he's not given that cake. Even though, so he goes, I know, but I want the cake anyway. So remembering again that residents have the same rights as you and I. I remember going through the scenario during training and problem solving with the other people in the class about, oh, well, you know, he needs to understand and this is better for him. And it was like, no, that was the wrong answer. He has a right to the chocolate cake. And just as you or I would. I mean, we don't ask for permission, and maybe it's the healthiest option, but he's an adult. He gets to make decisions for himself. He's the boss, so I advocate for him to get the chocolate cake if that's what he wants. We're just making sure that he's fully informed and understands the consequences of his choice. So it's our role to make sure he understands what he's requesting and the possible ramifications of that. So as we're in facilities and meeting with residents and talking with them, our major role is visiting with them and listening. And we'll investigate when it's necessary, and we'll take steps depending on what the situation is. The top complaint you can see is around discharge or eviction. And it's more nicely worded as an involuntary move out. It's happens on a lot in all kinds of different facilities. And I guess looking at this list, it doesn't pull out which one of these are around memory care issues, but it often happens in memory care when residents require a higher level of service. So eviction rules are set both at a state, by state and federal law, but unfortunately, if a facility, a long-term care facility tells a resident that they have to leave because they're difficult or they require too much care, a family may panic and move, not understanding that their loved one has rights to protect them, and they'll believe what they're told. If someone's given an involuntary move out notice, they can appeal that notice, and they have 30 days. And state ombudsman can get involved. There's potential for a hearing. There's a process that has to be followed. And actually, in the last 6 months or so, there's a lot more required of facilities to make sure that they're doing all they can to prevent getting to the point of where they're asking a resident to leave. So I unfortunately have a situation in one of the facilities that I work in where a family was told that their loved one needed to move because she required too much care. And in this situation, ironically, nothing had changed. Her level of care had not changed. Her health had not, her care needs did not change over the previous 3 months. She was doing the same, but needed quite a bit of care. So she was, family was orally informed, this was a memory care, that she required more care and they needed to move. And they gave her a list of places to look and wished her luck. And family was devastated, hurrying, trying to find something out, and ended up moving. The facility was in Corvallis, and they ended up moving their mom to Albany, farther away from their home, and also paying $2,500 move-in fee. And they had been told when they moved into this memory care that by their marketing person, that this was their mom's final resting place. This was her home until she died. They would take care of her. And unfortunately, that was not the case, that when care needs reached a certain point, facility had planned on asking her to move. So I didn't find out about this until after the fact. And that's just one example of care needs, or in memory care, it's often an increase in behavioral expression from people with dementia. And families are told their resident needs to leave. And it's like, where do you go if you're in memory care? You know, you expect when you're going into memory care that people have a higher level of training, and that's where your loved one is going to stay until they pass. So it's unfortunately that long-term care facilities will follow their standard operating procedures, and they do violate resident rights. So it's very important in any kind of situation where someone's issued a move out notice that they appeal that immediately, because that gives them another 30 days to find out what's going on and look at other options. Next slide, Helen. So I've been a long-term care ombudsman for 3 years, and I went through some pretty extensive training to do that. And you are not just turned loose on your own. We are supervised by a deputy ombudsman. So that's part of the state staff, and they are assigned different areas of the state. The area I'm in is Linn, Benton, and Lumina counties, and we have a deputy ombudsman who is available to us by phone or to meet in person. And we have monthly meetings where we have the opportunity to network and problem solve. We have ongoing continuing education, and it's just a great opportunity to meet with your peers, other ombuds in your area, and talk about situations in their facilities, and just learn from each other. There's also a deputy on duty. That's someone that's available at the 800 Ombuds number from 8 to 5, Monday through Friday, for families or residents to call in, but certified ombuds can also call in with questions when they can't reach their own deputy ombuds. So another important part of training that we learn is that you don't have to be an expert. You just really have to care. And it's okay not to know everything. You can ask for help or ask for clarification and get back to the facility or the resident if there are questions. So at the bottom of this slide, and I think we'll go over it again, is the 800 number. For either questions or concerns about someone you may know that's living in assisted living, or if you're interested in becoming a volunteer ombudsman. And the website is right there, www.oltco.org. And I'm going to turn it back over to Helen.
Thanks, Diana. Diana is too humble to say, but one of the things that Diana did as an advocate was to partner with Sarah Gelser to get a law passed that would prevent facilities from not having transparency in their marketing. So the story that she described of a facility marketing that this would be, a loved one's, final place to live, that they would be able to manage the care until that person died, but then to end up giving that individual a move out notice because they were not going to take care of all of their needs. That has changed, and facilities now have to be transparent about it, and that is all due to Diana Allen's work with Sarah Gelser. So yay, Diana.
Dr. Gow, I have a question about that transparency.
Yes.
And this might be for Diana. Do the complaints that are filed against these facilities, are those made public? If you want to move in somewhere and you want to see, does this facility have a lot of complaints maybe against it?
Diana, I don't know if you want to.
Yeah, that is an excellent question. And yes, it is so important to be an informed consumer. And part of when I said what I wish I knew, I wish I knew some of those things about asking questions about. There's something called the Uniform Disclosure Statement that is in detail about what the facility does and doesn't do and where the extra costs are. And what Helen just talked about around the move out is facilities are supposed to be more transparent in the levels of care that they provide. If they don't provide individual one-to-one assistance with feeding, if that becomes a need at some point, they need to say that up front. That can't be something thrown at you later. There is a site, and I think I can put that in the chat, where it's a licensing lookup with DHS, where you can go and look up facilities either by area or by name and see what kind of complaints have been filed. And what's listed there is when there's substantiated complaints. The bad news about that is it is way behind. The state does not have, it's not real time. I mean, it's months and months behind in posting what kinds of violations facilities have been fined for. So something that may not look too bad, or it's like, oh, they haven't had anything since 2019, might mean it's just not up to date posted. And I don't know what to say about that. It's just that it's known that things are not up to date, but it can give you an idea of what kind of things facilities are facing. So I will put that in the chat.
Yeah, it's very common for families and residents to be shocked when they learn that a facility can't manage two-person transfer or do one-on-one feeding. So these are things, and or that if they do, it costs extra money. It's a line item extra charge on the monthly bill. So these are all things that I think are really important for people to explore when they're looking at facilities, and because you might think that your loved one can get the care that they need right now, but you don't know what it's going to look like in a year or two. Okay, so I want to talk, of course, about the huge elephant in the room that we've all experienced in the past, year and a half, which is COVID. So the facility restrictions that I think we've all seen, for those of us who have had personal contact with residential long-term care settings is that all facilities, for the most part, stopped communal dining services and activities. Most of them stopped shuttle services to activities. They stopped visits from, quote, non-essential personnel, generally also including family and friends. There was a clear lack of coordinated guidance from federal and state agencies, and many facilities interpreted guidance their own way. And, Diana and I can tell you, very upfront that, multiple phone calls and emails with the actual surveyors from DHS, and even the surveyors from DHS were confused about what the guidances meant and who was restricted, who was not, et cetera. So complete chaos in the long-term care industry and oversight. And the result was that residents' rights were severely compromised. And I'm not just talking about things that we expected to happen, such as residents, of course, needing to be, in the same way that everyone was asked to kind of hunker down and be in their homes and be in their pods, that residents' rights were compromised beyond what was kind of typical for people living in a private home. The real world kind of system-wide problems that happened in long-term care, so long-term care facilities in general are like the black sheep of healthcare. They were not prioritized for personal protective equipment and testing in the early months compared to hospitals. There was a huge caregiver workforce shortage in Oregon and in this country, and it's confounded by a lack of caregiver living wages and protections. So this hit long-term care facilities and community living adults hard. Many of you have probably experienced that it is extremely difficult for people living in their own homes right now to find well-trained or adequate, private duty caregivers. The same goes for long-term care facilities. They are running short-staffed or they are having to fill multiple individuals into what might normally have been a fewer number of individuals, to staff their facilities. So to that next bullet point, which is that a higher number of unique direct care workers are rotating in nursing homes. And what we saw is that when you have a higher number of individuals rotating through a facility, the studies found that there was an association with greater number of COVID cases and deaths, not surprisingly. In Oregon, the long-term care ombudsman and certified ombuds corps were restricted from investigating complaints in person and advocating for residents, as Diana mentioned. So a lot was done by telephone. DHS, which is the oversight agency in our state, really struggled to maintain routine annual facility surveys to prioritize those with COVID outbreaks. So, this is not to chastise DHS. They are good people and they really try hard, but they are probably understaffed as well. So in the last year and a half, most facilities are required to have an annual survey, and DHS fell hugely behind, and they really began only surveying those facilities that had an actual COVID case. So facilities that lucked out and did not have a COVID case, nobody had any clue what they were doing because nobody was surveying them. You didn't know if they had PPE, if they were wearing it appropriately, what their staffing levels were like, et cetera. It was a complete black box. So what happened in Oregon were some very real world outcomes. In Oregon, half of all COVID deaths occurred among residents of long-term care facilities. And it's probably more because this doesn't include numbers from adult foster homes. In the US, we know that 40% of Medicare beneficiaries were diagnosed with COVID-19 or likely COVID-19 in 2020. And there were about 1,000 excess Medicare deaths per day in nursing homes in April 2020 compared with April 2019 pre-COVID. And what does that mean when we say excess deaths? It means that even despite kind of COVID itself, that people were dying probably of other reasons besides COVID during the COVID pandemic, that deaths were not solely due to COVID. Amongst assisted living facility residents, we've seen a 17% higher overall mortality in 2020 compared with 2019. And this is up to 24% higher in the 10 states that had the greatest community COVID-19 spread. And this is comparable to what was happening in nursing homes as well. So I think for those of you, again, who have been in nursing homes and long-term care facilities, you've seen this amongst your loved ones, and we've certainly seen this on hospice. We have nursing home residents, 76% of them who are reporting feeling lonelier. There's significant social isolation. So a study done of nursing home residents last year, kind of midway through the pandemic, almost 2/3 of them had never left their room. 87% did not eat in a dining hall, and only 28% went outside at least once a week for fresh air, compared to 83% pre-pandemic. So this is photos that were published by AARP of a woman called Helen, who was age 99. This was her in May of 2020, and then in July, just 2 months later, there was no illness or other physiologic reason for her decline, aside from the fact that she became extremely isolated, lonely, began losing weight, and ended up on hospice and died. And that is not unlike cases that we have seen in our own hospice. So these are the outcomes that we see: loneliness, social isolation, increased rates of depression, lack of a drive to stay alive, what we call failure to thrive, weight loss, declines in cognitive function, especially among individuals with dementia who suddenly had a huge drop in any kind of social or stimulating engagement, and excess mortality that was not due to actually getting infected by COVID-19 itself, although certainly we saw huge rates of COVID-19 related deaths in Oregon and around the country. So what can you do to advocate for your loved one? What Diana and I hope you will do, either yourself or amongst people you know who have loved ones in long-term care facilities, is to raise health concerns with primary care providers. Request care plan meetings to review care plans and to be sure that facilities are actually following through on the care plans that they have written. Sometimes it can be helpful to request a primary care provider write a specific order for something, even if it's not a medication. So I think we're used to primary care providers giving orders for aspirin and different medications, but primary care providers can also give explicit orders for feeding and hydration and wound care and rotating a person in bed for mobility, etc. And sometimes having that specific order allows the facility to be better about carrying it out. And then being really explicit in care plans. So I think it's helpful when you're moving someone into a facility to share what you know about your loved one, best approaches and tips for the caregivers. So for instance, if you know that your loved one with dementia responds better if you approach him or her in a certain way, with a certain tone of voice, by calling him a certain endearment, providing certain types of food that they are more likely to eat. All of these are tips that would be so helpful for you to share with the facility. And then to be sure, as you're reviewing care plans, that they're actually following through on those with your loved one. And then, as Diana mentioned, when you have a concern and something is not being addressed, you are worried about your loved one being neglected, or that the level of care is not being provided based on the care plan, please contact the long-term care ombudsman. The numbers that we showed you in the top 10 list are a far cry lower than what we know actually goes on, because, as Diana said, many people are fearful of retaliation, especially in a small setting like an adult foster home, where your caregivers are sometimes living with you in the adult foster home. But there are protections for people to not get kicked out of their home, to make complaints to the long-term care ombudsman. And unless we can truly tally and deliver to DHS the level of complaints and the gravity of the situations that is happening in long-term care facilities, a lot of things will continue to kind of slide by under the radar. So the more people are squeaky wheels, the more I think we can improve long-term care for our loved ones now or in the future. And so I'm just going to put a plug. I realize, we also recruit for volunteers at Lumina, but, please add your voice to advocate advocate for change. If you are open to being a certified ombudsman, or if you know someone else in Oregon or honestly anywhere in the country who might be, right up the alley to being an advocate and investigative support in this role, please consider that. And also provide testimony for legislative bills promoting reform. So for instance, Sarah Gelser's bill to have specified staffing ratios for memory care. Both Diana and I and our colleagues with the residential ombuds and Public Guardian Advisory Board provided testimony for that. And your voice is important, and it's particularly important if you deliver your stories to your district's legislators. Know your loved one's rights, be a squeaky wheel, and refer complaints to your ombudsman, and the phone number and the website I've just put here again. And with that, I'll probably leave this slide up. Diana and I are open to taking questions.
Go ahead and put any questions you have in the chat. Let's see, we did have a couple come in during the presentation. So we've talked about, speaking up and not being afraid to speak up, but if there's any tools or tips that you might have for raising concerns with facility staff. There's sometimes in that industry a lot of turnover, and especially right now, they might be understaffed. So I think a lot of us might be afraid to bring up a concern without causing issues. So if there's any kind of tips or tools that you can share with us to raise your concerns, but not cause any problems for your loved one that's in the facility.
Diana, do you want to take that one?
Yes. Okay. Sorry, I couldn't unmute myself. I'm trying to recapture what you just said, Holly.
How to raise concerns with caregivers and staff.
So there, depending on what the issue is, sometimes there are more systemic issues within a facility. Things like maybe there's questions around activities or around meals or something that might apply to more than one resident. So if I get a complaint, I'll go and talk to a resident, and my talk with that resident is confidential. When I go visit facilities, I don't tell the director who I'm seeing. I'm here to visit. And if I got a specific complaint, I will go talk to that resident. And then I'll try and find out if there are other people that maybe have the same issues. Maybe there's issues around housekeeping or something like that. Because if there are, I can talk to other residents and present something to the facility as a group complaint saying, I've heard from X number of residents. So it doesn't go back on any specific person if they're concerned about that. Where it gets a little more difficult is if the concern is unique to that person, if it's around care planning issues or something like that, it's still a point of where I need to get permission from the resident to talk to the facility about that. And one thing that I've done and that I like to do, if requested, is go to a care plan meeting with a family, with the resident or with the family, depending on the situation. And it's important, when at all possible, to get a copy of the care plan ahead of time. So it gives you time to look at it and go over. And as Helen mentioned, if you've offered up tips and suggestions in the past, are those included? And because you may bring them up and you want to make sure that it actually happens. And what happens sometimes is there's some touchy subject. And what I'll do is I'll ask the question as the ombudsman, so the family's not even asking it. I go, well, what about this? I see this in the care plan. And so I'm sort of taking the heat instead of it falling on the family. And I think that helps sometimes. And part of it is as Helen mentioned, the communication is really key, and having a copy of that care plan, because it really is a roadmap to your loved one's care. And the things that are important in there, is it the use of a gait belt? That needs to be in there. Are you seeing that happen? Are caregivers using a gait belt? to transfer someone. Sometimes those things get left off, but the care plan is the tool that caregivers look at. And especially as Helen mentioned, more with staffing issues, you have people coming in from outside agencies providing care. So they're having to look at that care plan to know what to do with the resident. Hopefully that helps.
Yeah,
There was a
thank you.
question in the chat about who qualifies for adult foster care, and for every facility in foster care has criteria for what type of activities of daily living needs someone has, and so it has more to do. I mean, I think that someone can qualify for assisted living facility and qualify for adult foster care. It really depends on what personality fit you're looking for. Is a smaller, intimate home environment better than a large, group congregate setting where there's more social activities, and for someone who perhaps is very social and likes to engage a lot with other people, or does someone need a quieter kind of place? So it really, I sort of tell people that finding a long-term care residence for your loved one is like dating. You kind of need to like shop around and see what the personality fit is for the person that you're looking for.
I have a follow-up to that question. Do any of the facilities that you shared in the chart require some kind of physician's referral to actually live in that facility, or is it pretty much an open choice?
So physicians are always required to be part of the process in that they give the orders for medications and any nursing level type of care, so whether it's wound care, glucose checks, Foley catheter care, et cetera. I mean, what we've seen is that over the past decades is that the kind of individuals who previously lived in nursing homes now live in assisted living. So the level of care needs that people can be in an assisted living facility in the old days, they would have been in a nursing home. So there is a lot of sort of peri-medical stuff, quasi-medical stuff that happens in assisted living facilities. So families and residents can choose their facilities, in discussion. It is like true marketing. You shop and find the place that you like. They do an assessment based on your loved one's functional needs and whether or not they can meet those needs. And then the primary care provider, always has to be involved to give the actual orders.
Okay, thank you. I'm not seeing any more questions come in unless someone's messaged you directly.
Someone did message, are there any statistics on evictions on a care facility basis? So we don't have a breakdown by facility of evictions. Unfortunately, that's not available. And again, and actually Diana just put up some information on the chat if you have it. So yeah, that kind of granular data is not available. And I will say that the data that you can find on DHS for the complaints that have been substantiated, again, it's not only backlogged, but I will say that this is just from being on the ground in the homes. Diana and I are sometimes surprised at what we see at the lack of substantiated complaints on facility lists. And I don't know if it's because it's backlogged or what's happening with surveys, but I think people show a brighter side of themselves. I think facilities show a brighter side of themselves when they're being surveyed than, of course, when they're not. Are there sufficient beds for people needing care? Boy. Really varies by region, certainly much tighter in rural regions than urban. But again, a huge problem in our country overall is that we don't have the caregiver workforce. And let me first say, Diana and I are huge advocates for caregivers, CNAs, non-skilled caregivers, informal caregivers. They are hugely underpaid. They have no benefits. They have no protections. It is something that makes me very frustrated, and that we are trying to also advocate for legislatively, because until we can provide people with a living wage and protections, we're going to have a massive caregiver shortage in this country, and we will never be able to adequately take care of the people who are aging with some kind of disability. It's great when they qualify for hospice and they can get some, hospice aid time, et cetera. But, unless you are Medicaid, unless you are financially well off and you are in the middle zone of being middle income or just above Medicaid criteria, it is a huge problem in our country that we lack the ability to take care of people who have served this country and now need our help. Let's see. Oh, that's a great question. If your loved one is in another community or state, how can you best stay involved in their care and oversight of the long-term care facility? I mean, I will say in some ways things are a little bit better because so much is happening by Zoom or Zoom corollary now. So having care plan meetings with the facility, your loved one and yourself by virtually is certainly better than just by telephone, because you can at least see people face to face. So I think still being involved in those care plan meetings, the care plan meetings are the crux of kind of how care is delegated. So that is staying involved in that, I think, is really important. If you are able to have someone in the local vicinity who can be an advocate for your loved one and visit them in person and report to you, that's all the better. If you can't go physically yourself to visit. If family believe their loved one's POA is not following the patient's wishes, do they go through ombudsman or legal counsel? That is a great question. That gets more into legal and guardianship rights issues in terms of decision making. So that's something I think less for ombudsman, as I would go on the side of legal counsel. Powers of attorney are supposed to act on behalf of their person and to make decisions purely in the benefit of the person, whether it's financial or healthcare or otherwise, and not for any other reason. And so when there is concern that a power of attorney is not appropriately upholding their role, that needs to be, I think, taken to, you can go to legal, you can try legal aid services or mediation with the family and, through those routes, short of getting that person under other protective guardianship.
Yeah, that's just to add to that, that's a really difficult situation when, especially maybe there's part of the family's from out of state and there isn't agreement on the care being provided. And in the case of a POA, it would be, if the ombudsman was notified about this, what we would immediately do is go talk to the resident and get their perspective on what's happening. And are they happy with their care and the representation they're getting from their POA? Because if they are, I mean, that stops right there for me, and I can let the person know that, but it's what the resident, if they have the ability to make decisions, what they want.
Yeah, I do think that there is also, sorry, I should have said a role for the primary care provider. If you have concerns that a power of attorney is not upholding the wishes, because theoretically, if someone is their power of attorney has been enacted, it generally means oftentimes that the person for whom that POA has been enacted has some deficit in some type of ability to manage those affairs themselves. It can be helpful to get the primary care provider to get involved, just to reassess that person's cognitive abilities. If it's not totally clear that they are incapacitated in certain ways, to see what they are still able to understand themselves, whether or not they want to, if they are capable, to reappoint their power of attorney, and or to get the healthcare team involved. Is this a hard stop, Holly? Because it's 1:02.
Yeah, folks are feel free to hop off if you have to attend another meeting. As long as you guys are okay for time, I think we can do one more question.
Okay. There's one in the chat. To what degree do primary care providers know and care about geriatric issues? It's a mixed bag. There's a field and specialty of geriatrics for a reason, because it does require additional access training for a lot of the scope of knowledge and skills that we practice in geriatrics. That said, there's a huge move to try to sort of geriatricize all healthcare providers, whether primary care or otherwise. I mean, it includes things like neurologists and surgeons, et cetera. Right now, we actually have a task force in the state to try to see if we can pass a bill that would require at least 1 hour of annual training for all healthcare providers to learn about dementia, to recognize it, to know how to manage it well, to discuss it. And it sounds really peasly. I mean, 1 hour a year, but that may be all we can get. so that's where we're starting. But it is, it's a mixed bag. I think that there are really wonderful primary care providers who do provide fairly good geriatric care, and unfortunately some who just really had no exposure to geriatrics, learning in their training. So medical students and residents generally have some geriatrics, but physician assistants, other primary, naturopaths who are primary care providers in Oregon, many of them have no geriatrics experience at all.
Thank you. Okay, well, thanks everybody for staying on for an extra few minutes here. And thank you to our presenters, Diana and Helen. If in the next day or so, you will get an email with the recording of today's presentation, along with some of the resources that Diana shared in the chat. We'll share that with you as well. And also just keep an eye out for our next Illuminating series next month. It'll be September 21st, and we will be discussing healthy sleep habits as you age. So I'm looking forward to that. And thanks again, everybody, for being here today.